Hello and welcome to the Neuromuscular Junction. I'm your host, Dr. Mark Tarnopolsky from the Neuromuscular and Neurometabolic Clinic at McMaster University. Today's episode, we're going to talk about Duchenne and Becker Muscular Dystrophy. Duchenne muscular dystrophy is more common than Becker muscular dystrophy, but they're both fundamentally the same at the cell level. These are X-linked disorders, which means that the genetic mutation is on the X chromosome. Boys have an X and a Y chromosome, women have two X chromosomes. So generally, if there's a mutation on the X chromosome, women are protected by the other X chromosome, which doesn't have the mutation, and they usually will not manifest symptoms. There's a complex process where we randomly inactivate the X chromosomes. And for some reason that we don't entirely understand, some women can have what's called skewed X inactivation, where they will knock out more of the good ones and have more of the bad ones and can manifest some of the symptoms that we're going to describe. But women with X-linked disorders are never as severe as men. The classic disorder that was described is Duchenne muscular dystrophy, and we've known about that for 100 years, but the gene mutation was found in the late 80s. The mutation is in a gene called dystrophin. Dystrophin is a very large protein. The gene encoding for it has 79 exons, which are these little reading parts. Sometimes we think of them as book chapters in the DNA. And at the end of the day, what happens is if you don't have dystrophin, the contraction part of your muscle, which is what we call the contractile elements, your actin and myosin, which cause contraction, are tethered to the outer skin of the muscle called the sarcolemma through this protein called dystrophin. If dystrophin is not made and we lose that connection, then there can be a sliding and a tearing, if you will, of the muscle. What will happen then is the outer coating called the sarcolemma will break, calcium can come in, that can activate things called proteases, which can damage the muscle. Then we get things like oxidative stress, damage to the mitochondria, ultimately resulting in scarring of the muscle. So these nice, beautiful contractile proteins, which are what generates force, become damaged. We get connective tissue, which can't contract, fat, which can't contract, and eventually those muscles become weak as we get more and more scarring that occurs in the muscles. In boys with Duchenne muscular dystrophy, usually they look fine when they're young, but then by the time they're 3 or 4, parents or if they're going to a daycare will notice that the children are having difficulty keeping up. Going up a climber, for example, getting up from the ground when they're playing, for example, they'll notice weakness. And the weakness is usually in what's called the hip girdle region. So getting up, what you'll sometimes see is they will walk themselves up with their hands because the pelvis is so weak it's hard to actually lift the body up without having to use your hands. And that's called the Gower maneuver. Even getting out of a chair with the Gower maneuver, for example, you'll see people will push themselves up and they'll get up like this. Most people with Duchenne, with the weakness, will also have a sway in their back, and when they walk, they will have a waddling gait because of the weakness in the hip girdle. As that muscle's weakness gets worse and worse over time, eventually children lose the ability to walk. That usually occurs at about age 10 if you are not being treated with steroids. There's a drug called prednisone or deflazacort. These are corticosteroids, and they give you about an extra 2 to 2.5 years of ambulation before the weakness gets to the point where you end up in a wheelchair. So as the weakness progresses, and a boy's in a wheelchair, let's say from age 12.5 if they're on steroids, what we then notice is there's more and more problems they're noticing with the arms. So it'll be difficult to do your hair, lift the arms up, and eventually in your 20s, sometimes people are so weak they can't even feed themselves and need assistance with things like brushing teeth, eating, cutting food, etc. Unfortunately, the dystrophin is also expressed in the heart, and many children will eventually start getting some damage to the heart, which can result in a decreased ability of the heart to actually pump blood, called cardiac failure. The other muscle that's affected is the diaphragm, which is the muscle we need in order to breathe. And in your teenage years, we often start to see some challenges with that. And sometimes at night when you lie down and depend more on your diaphragm, people will need something called BiPAP to help to push the air in because the diaphragm's just not moving air in and out. And that's particularly a problem when you're lying on your back where the diaphragm breathing becomes more important. So with Duchenne, that's a fairly characteristic and what we call idiosyncratic progression of the disorder over time. Unfortunately, most people get to the point where there's cardiac failure or respiratory failure in their 30s or 40s. In contrast to Duchenne, there is a milder form called Becker Muscular Dystrophy. With Duchenne, the protein is completely absent, so there's a lot more damage to the muscle. With Becker, the mutation in the gene doesn't completely eliminate the protein product, but we'll have either a truncated piece, so the protein's a little bit shorter, or it's just not structurally as sound. And so we can get a disorder that's almost as severe as Duchenne, or one that's so mild we've actually had people not present till they're in their late 60s with weakness. So there's quite a spectrum of Becker's. But to a first approximation, we see the same thing, and that is the muscles around the hip girdle get weak, the quadriceps start to get weak, the ability to pull your arm up gets weak, and there can be this cardiomyopathy and some breathing issues. So from a treatment perspective, it's been well known now since the pioneering work by Dr. Birch Griggs and others who first did studies looking at corticosteroids. There's a number of ways in which the corticosteroids can provide benefit at the cellular level, and to some extent we still don't know exactly how they work, but they do improve function. So using either prednisone or deflazacort, we do see an improvement in function with the time till you end up in a wheelchair. We and others have shown improvement in breathing capacity. It progresses more slowly. Improvements in upper extremity function and even cardiac function are improved. So we do advocate that most people go on corticosteroids. The downside of corticosteroids is that they can cause increase in body fat. Eventually, they can actually cause some shrinkage of the type 2 muscle fibers. And those alone, as you can imagine, can be deleterious. If you've got more body fat, it's hard to pick up your weight. If the muscle fibers start to shrink, these big type 2 fibers, that can contribute to weakness. So although there's benefits on the one hand, there can be side effects. One of the ways to prevent some of the side effects is make sure that you have adequate vitamin D intake, which is also important for your muscle as well as your bones. Monitoring bones are very important. Prevention of falls, very important as well. So when we start thinking about that, we also realize that exercise could be of benefit. We know definitely that older adults who have osteoporosis benefit from exercise therapy. We know that regular exercise can decrease your fall risk. And if you have brittle bones or you're weak and more prone to falling, mitigating or slowing down or prevention of those falls is something that can help to prevent morbidity and mortality, such as breaking a hip or something more severe like hitting your head and causing issues as well. We also know that exercise can improve muscle function. Now, decades ago, people thought that perhaps exercise would further damage the muscle in Duchenne muscular dystrophy. But this was really based on completely non-translatable studies in mice. There is a mouse called the MDX mouse, which recapitulates some of the aspects of Duchenne dystrophy. These mice are not as severe, so they can actually run quite well. And so you can put them on a treadmill, run them very fast downhill, which does cause quite a bit of damage to the muscle. I can tell you, with 30 years of practice, seeing over 100 boys with Duchenne dystrophy, forcing them to exercise at a very intense, equivalent type of intensity just cannot occur. There's no way you can push someone that hard. And just like an adult, they'll say, that's too much, I'm not going to push that hard. So these studies are really practically irrelevant. And unfortunately, people made the translation from the mouse study to the human. And for years, people were told they were going to tear their muscle apart, they were going to damage their muscle. However, a number of studies have clearly shown that if you follow proper exercise prescription, listening to your body, starting off with lower intensity and/or weights, and gradually ramping up, you can derive benefits. And that's been shown, as I mentioned, in clinical studies, but time and time again, we see that in our clinic. For example, if we have two boys, one has ADHD and the other one doesn't, the boy with ADHD tends to be more active, and we generally see that they preserve their motor milestones for longer. When we prescribe exercise, as we do to our patients, those who follow our advice tend to have less accumulation of body fat, which is a good thing when you're on steroids because they tend to really increase your body fat, Less body fat, easier to get up from a chair, easier to do your daily activities. More body fat, greater cardiovascular risk, and as boys are becoming men and living longer and longer, we want to try and decrease risk of cardiovascular disease, which is definitely improved with regular, more endurance type of activity. In addition, bone health can also be improved. We know that with resistance type of activities such as weights or therabands, we can also improve bone structure and bone mass, and so that's another important benefit of activity. But again, like every disorder, listen to your body, start off low in terms of your intensity and your duration, take a day off in between to let the body recover, and in the very rare chance that you actually push yourself too hard and your muscles are really sore the next day and you start to get dark urine, do seek medical attention. That would be extremely rare if you follow our advice. And remember, don't work out if you've got a fever, you're vomiting and you've got diarrhea, you've got a cold or flu. Take that day off, let your body recover before you go back to activity. Stay well hydrated, don't work out if you've fasted for more than 12 hours, and do take a look at all of our videos to show you how to safely do endurance type of activity, resistance activity, and do enjoy yourself. There are some supplements which are beneficial as well, which can interact with exercise. The most well-studied in Duchenne dystrophy is something called creatine monohydrate. Creatine is what's called a guanidino compound. It's made initially in our kidneys. It then goes to the liver where another chemical is stuck on it called a methyl group, and we get creatine. All of us make creatine every day. Every human being makes creatine in their liver, about 1 gram per day, and we also get it if we have meat and fish. Unfortunately, because of the damage to the muscle membrane, we release we release a lot of creatine kinase, which is the activating enzyme for the creatine system. And as a consequence, we felt years ago that perhaps creatine levels would be lower in boys with Duchenne dystrophy and indeed all types of muscular dystrophy. And in 1999, when we actually did biopsies, we found that that was the case. So we were the first to do a randomized clinical trial in 30 boys with Duchenne dystrophy, published in the journal Neurology, where they were on creatine or a placebo for a period of time. And we found that in the dominant hand, which again probably alludes to the benefits of exercise, there was some benefit. We also saw increases in muscle mass, which is important as well. And overall, when we look at studies from Belgium, studies from Germany, studies from the United States, we see that creatine provides about a 7% increase in strength and a 7% increase in muscle mass, which may not seem like a lot, but that 7% is about equivalent to what we see with corticosteroids. And importantly, it's additive. So what we found is half of our boys were on steroids, half were not, and both derive benefits from creatine. We've gone on to do studies in rats where we gave them high-dose steroids, and we showed that it helps to protect the bone and it helps to protect against that type 2 muscle fiber atrophy. So we would definitely advocate that when you're exercising with muscular dystrophy, make sure that you're taking creatine monohydrate, usually 100 milligrams per kilogram. And the Cochrane review, even without exercise, concluded that this is helpful in muscular dystrophy, so we'd encourage you to consider that. We also find that a fairly high proportion of our boys and adults are deficient in vitamin D, so check that and replace it, because very low vitamin D will lead to further bone loss, and even low levels can cause muscle weakness, sometimes called ricketic myopathy. So vitamin D is clearly indicated when you're on corticosteroids, and even if you're not, most people are deficient, so get the levels checked and try and get them over 75 nanomoles per liter. There is some evidence that protein requirements are higher with muscular dystrophies. I'm involved in some research where we're using newer stable isotope methods to look at protein requirements, and hopefully in the future we'll have an updated video where we can give you the exact requirements. In general, we want people to be on about 1.4 grams of protein per kilogram body mass per day. So make sure eggs, meats, fish, milk-based products are part of your diet to try and get over that 1.4 grams per kilogram per day. If for any reason you're a vegan vegetarian, or you're not eating even eggs and milk, for example, make sure you have things checked with a dietitian so that you're getting the optimal combination of amino acids, and you may have to push that total amount up to 1.6 or even 1.8 grams of protein per kilogram per day. So on some of our subsequent videos, we show you how to perform different types of endurance activity. I encourage you to do what you enjoy, because if you enjoy it, you're going to do it and be compliant. And the main thing at the end of the day is to be compliant, doing this at least 3 times per week with endurance type of activity and twice per week of resistance activity. And you're only going to do what you enjoy. It's preferable to set something up at home, and we're going to show you all sorts of ways that you can use things like TheraBands, other resistance activities at home, weights, or if you want to go to a gym, there's a variety of different machines, some of them with pneumatic types of activation, others with plates that you can use. So please take a look at our other videos so you can learn how to use these things effectively and safely to avoid injury. And hope this video is of some benefit to you. Hope you enjoy your exercise, and it keeps you as strong and healthy as we can for as long as possible to improve your health span. If you have any other suggestions in the future, please subscribe to our channel and ring the bell for future notifications. Thanks.